Hello, everyone. Thank you for having me. First, a quick conflict of interest declaration. So, we've seen from the previous talks that cytomegalovirus, or CMV, is a very common opportunistic infection, 40 to 100% seroprevalence in adults. This graph here is specifically showing seroprevalence in women of reproductive age. I'm going to specifically talk a little bit about congenital CMV. So 1 in 200 babies is born with CMV. 10 to 20% of those are symptomatic. Congenital CMV is actually the #1 cause of childhood hearing loss that is non-genetic, and can also cause symptoms like developmental delay, vision loss, seizures, and even death. We've talked about it before, there are currently no approved vaccines for CMV, even though we've been trying for a really long time, and there's no cure for the disease. The first-line drug for congenital CMV is Ganciclovir, or its oral prodrug Ganciclovir, which works by entering the cell and getting phosphorylated by viral-specific and then host-specific kinases, and then inhibiting the viral polymerase UL54 as a nucleotide analog. It's really important to dose this drug optimally. As with all drugs, if someone has too little drug in their system, it can cause virological failure and create a breeding ground for drug resistance. If you have too much drug in your system, you can have toxicity or other side effects. We talked about the fact that Ganciclovir has a really high inter-individual variability. This is especially true for infants and pediatric patients. We see less than half of infants and pediatric patients on Ganciclovir receiving adequate exposure to the drug, with about 30% being underexposed and 25% at least being overexposed with significant toxicities. Now, therapeutic drug monitoring, some studies have been done with therapeutic drug monitoring of serum Ganciclovir, which has had mixed results. But we have seen a relationship between the active triphosphate version of the drug, Ganciclovir triphosphate, and neutrophil toxicity. This study was actually done in transplant populations, but it's the one study that kind of exists looking at this triphosphate version of the drug. And this data together suggests that therapeutic drug monitoring of Ganciclovir triphosphate specifically may be beneficial. Importantly, the graph shown on the right, no relationship was seen between serum Ganciclovir and neutrophil toxicity or other metabolites of the drug. What currently exists is liquid chromatography tandem mass spectrometry, or LC-MS-MS. It's the only method to measure Ganciclovir triphosphate. And this method is time-intensive, labor-intensive, and requires costly centralized equipment. Thus, there's an urgent need for more accessible Ganciclovir triphosphate monitoring tools. Now, one method for measuring the active versions of drug that require a little bit less processing than LC-MS are enzymatic assays. Earlier versions of these assays are limited by the fact that they use radiolabeled DNA and are measured in PBMC sample matrices. Taking inspiration from this work, the Owner Raju lab has developed the reverse transcriptase activity CRISPR assay, or the reactor assay, that enables the detection of reverse transcriptase inhibiting drugs, specifically NRTIs or NNRTIs, based on the levels of DNA synthesis by reverse transcriptase. The way this works is that with low drug levels, DNA can be fully synthesized, and we can measure that using a CRISPR-Cas12 enabled readout, which will bind to the fully synthesized DNA and trigger collateral cleavage of fluorescent DNA reporters. Whereas in high drug conditions, DNA synthesis is inhibited by your drug, Cas12 is not activated, and you're not getting any fluorescence, which allows us to measure drug levels by proxy by looking at the level of fluorescence intensity generated with our assay, as seen here. An interesting thing about reactor is that it can also be adapted for lateral flow assay detection, which my colleague Carrie will talk about more tomorrow. Reactor was originally developed to measure HIV drugs because it does measure the synthesis based off of HIV reverse transcriptase. But interestingly, evidence also suggests that Ganciclovir triphosphate inhibits HIV-RT alongside its canonical target UL54. which is valuable because UL54 is not commercially available. HIV-RT is much easier to source. And we already have this RT-based assay up and running that can be modified for use with Ganciclovir. With a bit of optimization, I was able to get Reactor to measure clinically relevant Ganciclovir triphosphate concentrations. These are spiked in buffer. To the left, you can see the fluorescent amplification curves of the assay over time. And then looking at one analysis time point at 60 minutes, the enzyme inhibition curve is shown on the right, showing that the dynamic range of our assay is overlapping with the clinical range of Ganciclovir triphosphate in infants with congenital CMV. We also wanted to validate this assay in clinical samples because buffer is great, but clinical samples are better. We collaborated with Dr. Joseph Rower from the University of Utah, who helped run the randomized controlled trial of Ganciclovir for cytomegalovirus infected hearing impaired infants, or the VAL-EAR study, where he measured Ganciclovir triphosphate concentrations in dried blood spots of infants in this study. And he was gracious enough to give us some of these dried blood spots for testing and comparing to gold standard LCMS measurements. To process dried blood spots, for our assay, we punched dried blood spots and eluted them in water, added proteinase K, did a few incubation steps, and quickly spun down on a microcentrifuge. We then took the supernatant of the drug, of the blood-containing drug, added it to the reactor assays, and read them on a fluorescence reader. This is the enzyme inhibition curve for spiked DBS. You can see that there's a very similar curve between buffer and spiked dried blood spots. And the dynamic range of our assay is still overlapping with the clinical range of Ganciclovir triphosphate seen in the VAL-EAR study, specifically at the higher end of this range where toxicity may be a concern. Finally, we saw a correlation between the reactor fluorescence and the LCMS-MS Ganciclovir triphosphate concentrations measured by our collaborators. Next steps will include shifting the enzyme inhibition curve of our assay to improve sensitivity and be able to distinguish between lower drug concentrations. And we know from previous work that we can shift variables like DNTP concentration and template length to achieve this. We also want to expand to other clinical use cases like transplant recipients, and we're lucky enough to be situated very closely to the Fred Hutch Cancer Center and have clinical collaborators that work closely with these populations. Finally, we'd like to validate the assay on a portable reader to improve clinical utility. I'd like to thank everyone in my lab, my collaborators, and our funders. Thank you.